endocrine therapy for premenopausal breast cancer. Personal data. My name is Arlet Bravo Montes and my teacher is Moscoso Escobar John Fernando. Definition. In the suppression of ovarian function trial and the tamoxifen and exemestane trial, the 5 years rates of recurrence of breast cancer were significantly lower among premenopausal women who received the aromatase inhibitor, exemestane plus ovarian suppression than among those who received tamoxifen plus ovarian suppression.
I'm here today to talk to you a little bit about the adjuvant treatment of breast cancer, and specifically for the type of breast cancer that is estrogen receptor positive. So in patients that have estrogen receptor positive breast cancer, there has been a great deal of research over the last 40 years that has demonstrated that the use of drugs that alter hormones in some way, either by reducing estrogen or blocking the ability of estrogen to bind to the estrogen receptor, leads to substantial reductions in the risk of recurrence, as well as in terms of prolonging survival. We think that for women who have estrogen positive breast cancer, really the most important treatment that we can give is likely hormonal therapy. That is, therapies that block estrogen. So there are two major classes of therapies here. One of them is the drug tamoxifen. Tamoxifen has been around for nearly 40 years. It is a drug that has been found to bind to the estrogen receptor, and in so doing prevent estrogen from causing tumor cells to grow. It is called a selective estrogen receptor modulator. However, tamoxifen can have pro-estrogenic effects at the level of the uterus. This may mean that for some women, tamoxifen can cause a slight thickening of the lining of the uterus, even leading to uterine bleeding. A feared complication of tamoxifen is uterine cancer, which occurs rarely at a rate of 1 to 2 to 3 patients per 1,000 treated with tamoxifen. Overall, tamoxifen has been shown to reduce the risk of breast cancer and specifically to prolong overall survival. So tamoxifen, if you will, is excellent at this gold standard, that is, in terms of not just reducing recurrence, but leading to prolonged life. The side effects of tamoxifen, I've mentioned the risk of endometrial cancer, which is very low. There's also a small risk of developing a blood clot. The women that are at greatest risk for blood clots are those that have a personal history of blood clots, those women who are sedentary or obese, and those women with a strong family history of blood clots. The other relatively newer class of drugs is called the aromatase inhibitors. And aromatase inhibitors work different than tamoxifen in that they lower estrogen. Aromatase inhibitors are only indicated for women who are postmenopausal. And these drugs, as I mentioned, act by preventing the body's normal steroids from being converted into estrogen. Aromatase inhibitors have been compared head-to-head with tamoxifen and have been shown to be slightly better in terms of reducing the risk of recurrence, but aromatase inhibitors lead to equivalent long-term survival. In terms of side effects, aromatase inhibitors are different than tamoxifen. The main side effect with aromatase inhibitors is some joint aching or muscle aching, and this is seen anywhere from 30 to 40% of patients. A side effect that is associated with lowering estrogen is bone loss. And so, for example, one of the side effects with aromatase inhibitors is a higher risk of fractures. And specifically, we're talking here about a risk of fractures of anywhere between 7 to 9% if a woman takes the aromatase inhibitors versus tamoxifen in that 4 to 6% range. However, it should be noted that there are good drugs that are available to prevent these fractures, and these are the bisphosphonates, which have also been shown to have some anti-cancer activity. Another side effect of the aromatase inhibitors is some effects at the level of the vagina, so there can be some vaginal dryness and or dyspareunia. Overall, we think that both of these classes of drugs are very effective for the treatment of estrogen-positive breast cancer, and we try to individualize our therapies for patients. For example, there are some women that start out with severe bone loss where we might think that tamoxifen is a better drug, whereas, for example, there are some women that might have a higher risk of developing a blood clot, and we may be more prone to use an aromatase inhibitor. It should be noted that for the treatment of premenopausal breast cancer, there's only one FDA-approved drug, tamoxifen. For the treatment of postmenopausal breast cancer, there, of course, are two classes of drugs available, tamoxifen and aromatase inhibitors. For more information, feel free to click on the link below. Otherwise, you can go to the Mayo Clinic book, which provides information with regard to aromatase inhibitors and tamoxifen, their benefits and side effects for the treatment of estrogen-positive breast cancer.
Application in medicine. The addition of ovarian suppression to tamoxifen did not result in significantly lower recurrence rates than those with tamoxifen alone. Premenopausal women were randomly assigned to receive 5 years of tamoxifen plus ovarian suppression or exemestane plus ovarian suppression in SOFT, and to receive tamoxifen plus ovarian suppression or exemestane plus ovarian suppression. In TEST, randomization was stratified according to the receipt of chemotherapy. Continue the video.
During the 10 years after breast cancer diagnosis, 5% of women develop cancer in their opposite breast, known as contralateral breast cancer.
We know from clinical trials that there are medications that can be used to reduce risk of contralateral breast cancer, particularly for women who are diagnosed with estrogen receptor positive breast cancer. Tamoxifen and aromatase inhibitors may be used. But we wanted to evaluate these medications in a general community healthcare setting to see how well they work in the real world.
Dr. Gretchen Gierach from the National Cancer Institute and co-authors reviewed the records of more than 7,500 women diagnosed with invasive breast cancer from 1990 to 2008. They followed the women through 2011 to see which ones developed breast cancer in the opposite breast. The researchers also recorded who took tamoxifen or aromatase inhibitors, two types of medications that block estrogen. Dr. Gierach's team found that women taking these medications for a longer period had a lower risk of contralateral breast cancer. The study appears in JAMA Oncology.
So for women who took the drug for 4 years or longer, we observed reduced risk of contralateral breast cancer for up to 5 years after they stopped taking the medication.
Women going through breast cancer treatment have many tough decisions to make in choosing a therapy plan. Dr. Gierach says if they decide to use these drugs and can stick with them, there are long-term benefits.
These medications, though, are known to have side effects which might impact or challenge a woman in being able to complete her full treatment course. The longer they took the drug, the greater the risk reduction, so we know that therapy duration really does make a difference.
Laura Berger, The JAMA Report.
Pros and cons. Pros. The 8-year rate of overall survival was 91.5%, with tamoxifen alone, 93.3% with tamoxifen plus ovarian suppression, and 92.1% with exemestane plus ovarian suppression among the women who remained premenopausal after chemotherapy. The rates were 85.1%, 89.4%, and 87.2%, respectively. Cons. Grade 3 or higher adverse events were reported in 24.9% 6% of the tamoxifen alone group, 31.0% of the tamoxifen ovarian suppression group, and 32.3% of the exemestane ovarian suppression group. Continue the video.
In this area of neoadjuvant endocrine therapy, doctors have become so accustomed to feeling that the only and best treatment is chemotherapy because it's a very dramatic and devastating treatment. And even patients say the same thing. Oh, I don't want to take chemo, but hey, I'll do anything. Just hit me as hard as you can. You know, I've got to be here for my kids. And increasingly in breast cancer, it's got to be the right treatment for the right disease. And so we don't think of breast cancer as a queen-size pantyhose of a disease anymore. It's different subtypes. And so one of the challenges that we're facing, even in a much more common scenario, that is, we are in the clinic and a patient comes to us after having had surgery. Her tumor is smallish, but it involves some lymph nodes. It's hormone positive. It has a slow growth rate. And so we struggle. Well, it's in the lymph nodes. Should we be giving chemotherapy? Or can she be treated more appropriately with anti-hormone therapy? So this is a big issue that we struggle with in early breast cancer. So even more in this situation, generally tumors are larger. Doctors and patients say, but I must have to get that chemotherapy, that terrible stuff, or you're not giving me the right treatment. So it's a matter of explaining, to getting the information out there that it's the right treatment for the right disease. And the second part of that is identifying those patients, because there are certain features such as a low growth rate and very strong hormone receptors. But now more than ever, we are using genomic classifiers to actually look at the genes that are the hard wiring of the tumor. So I think the challenges for the future are to let people understand that as Lance Armstrong said, it's not just the bike. Breast cancer is not just chemotherapy. It's targeted therapy, the right drug for the right disease, and then figuring out what is the disease by getting these new tests that are helping us to integrate the clinical picture of the size, the lymph nodes, the growth rate, and other gene components to the tumor.
Usually, there is not much information on the subject in Ecuador because the study was conducted in New England on July 12, 2018. Continue the video.
Breast cancer is a heterogeneous disease, but when in 2003, 2004, when we had these genomic tools for the first time, we divided breast cancer into 4 subtypes. The triple negative, or what we call the basal subtype, which is about 15% of breast cancer. And then the HER2, the HER2 amplified type of breast cancer, which is another 12% or 15%. And then the remainder, which is over 70% of breast cancer, are the hormone receptor positive breast cancers, what we call the luminal type. And these cancers on their cell surface have hormone receptors, estrogen and progesterone receptor. And these cells really, in order to survive, must get estrogen in some way. And so our therapy to prevent these women from, these tumors from getting estrogen, is to use either a tamoxifen-like drug, which is an estrogen molecule which goes right onto the surface receptors and blocks them very tightly. And so the cell, in a sense, doesn't get the, quote, fertilizer it needs, it kind of suffocates and it dies. But it takes time to do that. The other method is that once a woman goes into menopause, her ovaries are not making estrogen anymore. The tumor can be kept alive. The cancer cell can be kept alive from a small amount of estrogen coming from the adrenal glands. And so we can prevent secretion of adrenal estrogen by using a drug called an aromatase inhibitor. And there are 3 of those. That's the other class of hormonal therapy. So 70+% of women have this hormone receptor positive type of breast cancer. And almost all of those women are prescribed in the beginning tamoxifen. We know that of that 70% of all breast cancer, probably 60 or 70% of those patients, those women, don't really need the drug because they're cured with their original surgery.
Conclusion. Among premenopausal women with breast cancer, the addition of a variable suppression to tamoxifen results in significantly higher 8-year rates of both disease-free and overall survival than tamoxifen alone. The use of exemestane plus ovarian suppression results in even higher rates of freedom from recurrence. The frequency of adverse events has higher in the 2 groups that receive ovarian suppression than in the tamoxifen alone group. Continue the video.
Endocrine therapy is the most important treatment for patients having an endocrine dependent, so estrogen receptor, progesterone receptor positive early breast cancer. We know that for almost 40 years, and we have been treating with anti-endocrine therapy or anti-endocrine treatment for more than 1 century these patients, mostly with ovarian suppression by surgery in the early last century. So at some point in the past, we questioned the value of ovarian suppression because it was replaced by endocrine treatments like tamoxifen. Okay? But the question remained if increasing or adding ovarian suppression to tamoxifen could increase the activity and the prevention way for patients being premenopausal with endocrine sensitive tumors. Unfortunately, for many years, the trials were run with a lot of problems and caveats. The major one is that patients also receive chemotherapy, so chemotherapy influenced the menopausal status. And finally, the trial didn't show any benefit from adding suppression function. But in the last 10 years, we run 2 important trials where the design was very well done. So patients were able to be introduced in the trial if they preserve her hormonal status at the time after chemotherapy. So be sure that all patients were premenopausal. And the combination of the 2 trial analysis clearly shows that when you combine the ovarian suppression function with endocrine therapy, the benefits are superior to tamoxifen alone. But again, this superiority doesn't mean that all patients should receive this combination treatment. It's a new option. It's an option that could be recommended for patients with high-risk tumors. So right now, the problem we have in early breast cancer premenopausal patients is not so much about considering that it's a good option, the suppression of ovarian function and endocrine therapy, but about what are the good candidates for this treatment. Because in fact, the major problem is that you are also increasing toxicities. Probably not heavy toxicities, that very uncomfortable one. So you have loss of sexual appetite, you have weight gain, you have hot flashes, in a way that for some patients is really very disappointing, and it affects a lot her quality of life. So it's a question of balance, in which it's not just the decision about which is the best treatment, it's also a negotiation with the patients about what are their objectives. And in some circumstances, what we can try is we can try to apply this treatment.
Thank you.